Good morning, respected seniors and my colleagues. I'm Dr. Asish Kharel, and today I'll be talking about multiple primary lung cancers. So, multiple primary lung cancer, or MPLC, refer to cases where there is more than one primary cancer simultaneously or sequentially in the lung. So, they can either be synchronous, that is, they present at the same time, or metachronous MPLC, where the two tumors are present one after the other. And so this entity was first reported in 1924 by Bailey, and the main challenge in differentiating this entity and studying this disease is to differentiate it from intrapulmonary metastasis. So obviously, if there is metastasis from another lung cancer, so the staging and the treatment will be different. So it is important for us to understand this entity and know how to differentiate it from the intrapulmonary metastasis. So coming to epidemiology, MPLC occurs in approximately 0.01 to 0.54% of individuals who are screened for lung cancer, and accounts for around 2.5 to 20.8% of all newly diagnosed lung cancer cases. And it has been shown that there is a growing trend of in the proportion of MPLC patients among newly diagnosed lung cancer patients from recent studies. So coming to risk factors, the most important risk factor for MPLC is smoking history, as is for the isolated lung cancer. So this is because of the effect of field cancerization by tobacco and its carcinogens, which result in multicentric lesions that can arise in the benign contiguous tissues. So another is it has been shown that female patients have a higher proportion of multiple lung cancers as compared to male patients, and a previous history of lung cancer is a very important factor for a second primary. So second primary again is a metachronous. We can classify it as metachronous multiple lung cancer, and so a previous history of lung cancer is an important risk factor for development of a new lung cancer. So many studies have shown that the prognosis of multiple lung cancer is similar to stage matched solitary lung cancer. So it's important for us to differentiate it from the metastatic diseases. So this is the figure showing the various risk factors that may cause multiple lung cancers. So the main thing is that there is a field cancerization by tobacco smoke and other multiple carcinogens, leading to the mutations over a large field of normal-looking mucosa, which can lead to multiple sites of independent neoplastic growth. So again, another thing is that there may be germline mutations in various genes, which will also predispose to development of multiple lung cancers. So, what are the diagnostic criteria and how do we differentiate it from intrapulmonary metastasis? In 1975, Martini and Melamed, they first proposed the diagnostic criteria for multiple lung cancer, and this was later on modified by multiple authors. And currently, the latest one is by the International Association of Study for Lung Cancer, published in 2016. So for synchronous lesions, the diagnostic criteria is that both the lesions must be malignant and must arise independently from the lung. That is, we should exclude without any doubt whether it is a benign nodule and infectious process or metastasis from any extrapulmonary site. Following this, the second malignant lung lesion must not represent a metastasis from the first lesion. So this again is differentiated by various points. So it may have a different histology or origin from a separate focus of carcinoma in situ. If the histology is same, but it is anatomically distinct, such as it is present in both the lungs, then there should not be involvement of the mediastinum. That is, it should be an N2 negative disease and should not have any systemic metastasis. If there are suspicion of two primary lung lesions and the mediastinum is involved, then we suppose that it is a single primary lung lesion with multiple metastases. Again, the disease, both the tumors may have the same histology, but based upon the comprehensive histologic assessment, it may be different. So this is also criteria to distinguish between the two lung tumors. And finally, doing the different biomarkers, we can utilize the gene sequencing techniques to differentiate the two lesions. In case of metachronous lesions, patients with a history of previously treated lung cancer, they are at an increased risk of development of second primary. And again, we should first distinguish whether it is a benign nodule, an infectious process, or a metastasis from extrapulmonary primary. And after this is excluded, then the tumors are considered metachronous if the histology is different, or if the same histology, there is a 4-year or greater interval between the cancers, with no evidence of systemic metastasis. So this is the definition that has been provided. So what are the staging implications and why do we have to differentiate it from from an intercolonial metastasis? Because the staging will be different. So if there are two tumors in the same lobe, it is T3 occurring to the AJCC TNM 9th edition, and if it is in the different ipsilateral lobe, it is T4. And if the two tumors are in contralateral lungs, then it is an M1A disease. So obviously, if there are two primaries, then they will be staged separately, and the staging will be low, downstage. The staging will be low. But again, if you consider the tumors as the same disease, then we will have to upstage the disease, and this will lead to a change in management and prognosis of the patient. So coming to histology, there is an increasing prevalence and proportion of adenocarcinoma in lung cancer compared to squamous cell carcinoma and small cell carcinoma. This is a worldwide trend, and it has been seen throughout the Western countries, in India. And recently, in our study, we found out that squamous cell carcinoma is still the higher prevalence compared to adenocarcinoma in our country, especially in our institute. But the relative percentage is decreasing. So nowadays we expect to see further in the future that adenocarcinoma will be the greater histology. So similarly, this is same for the multiple primary lung cancer as well. And so the most common and likely clinical scenario will be a patient with two lesions, both of which are adenocarcinoma. So in this case, it is important to differentiate these two tumors. And for this, advanced molecular DNA testing, testing such as DNA fingerprinting, may be helpful. Maybe this will be in our center, as we don't have the DNA fingerprinting technique. Maybe we will have it in the future. But for our center, use of molecular markers or NGS panels will be the most useful criteria to differentiate these two tumors. So this is a diagnostic workflow on how we could differentiate the two primaries. So obviously, if we suspect that there is a multiple primary lung cancer, then biopsy should be taken from both the tumors. So first of all, we do the histologic assessment, and if the histology is different, then obviously it is a multiple primary lung cancer. But if it is similar, then we should differentiate it whether it is a squamous cell carcinoma or adenocarcinoma. And for a squamous cell, if both are squamous cell carcinoma, TP53 mutation testing is done, and if the mutational status of the TP53 mutation is different, then it is multiple primary. Whereas if it is identical, then it is an intrapulmonary metastasis. Further, we can do the comprehensive molecular testing to further differentiate IPM from MPLC. And if it is an adenocarcinoma, then we differentiate whether it is a mucinous or non-mucinous. If it is mucinous, then we do a KRAS mutation study. And then again, if the mutational status is the same, it is an IPM, and if it is different, it is a multiple primary. In case of non-mucinous adenocarcinoma, we do other testing, that is AIS, MIA, and if these are different, then it is MPLC. Further evaluation, if it is same, then we do further evaluation to differentiate whether these are same or not. So this is the sample workflow to see to evaluate whether it is an intrapulmonary metastasis or a multiple primary. So I don't think this is we usually do in our center these studies, but this should be incorporated probably in the future for our patients also. So coming to synchronous multiple primary, the main problem is with diagnosing the synchronous multiple primary, and again it requires tissue from both the tumors, and before further study, we should stage the patient properly with MRI brain and PET scan to rule out extrathoracic metastasis. If there are any extrathoracic metastasis, then obviously we assume that both these tumors are from the same primary, and this is a systemic disease. And if the tumors are more than stage 1A, that is they are more than 2 centimeter, then we do the mediastinal staging also, and to confirm whether there is a mediastinal disease or not. For tumors that are stage 1A, mediastinal invasion is usually absent unless there is definitive CT or PET evaluation that the nodes are larger. If the nodes are negative in the cross-sectional imaging and the disease is stage 1A, usually mediastinal staging can be avoided. Also, if you are planning for definitive dissection of the tumors, because there will be a large loss of pulmonary volume, in these cases also mediastinal staging should be done to rule out any incidental mediastinal disease. So this is because invasive staging of the mediastinum provides additional information about the potential for surgical dissection and assists in clarifying whether the patient has two synchronous primaries or intrapulmonary metastasis. So in patients in MPLC with similar histology in both tumors, the treatment depends on the certainty that the two lesions are indeed distinct. Whereas in patients with the that is so if the patients have multiple tumors with the same histology and N2 nodal involvement is present, then generally we treat it as stage 4 disease, because the patient has already the mediastinal involvement, and usually in these cases surgical treatment is not curative. So we usually go for palliative treatment in these cases. But in MPLC with differing histology, the treatment should be based upon the on providing the best long-term outcomes, and each tumor is evaluated separately, irrespective of the other tumor, and the staging is done similarly, and definitive treatment is also planned accordingly, especially according to the tumor with the higher stage. So surgery is the standard approach of treatment for patients with either synchronous or metachronous multiple primaries if there is sufficient pulmonary reserve. as we have to resect large volume of pulmonary tissue, usually in both the lungs. So the pulmonary reserve should be evaluated, and for patients with limited pulmonary reserve and small volume disease, sublobar resections may also be appropriate according to the Alliance study, where for tumors of stage 1A, there was equal oncological outcome for patients with lobectomy, undergoing lobectomy, or sublobar resections. So other approaches in patients with a limited pulmonary reserve could be the stereotactic body radiotherapy, percutaneous image-guided tumor ablation using RFA or infrared, or conventional radiotherapy. This is especially useful in patients with who present in old age or with a very poor pulmonary reserve. Coming to metachronous multiple primaries, many patients who are successfully treated for lung cancer will develop a second primary lung cancer, and studies have shown that the median time interval between the primary and the new lung cancer is 38 to 48 months, so around 3 to 4 years of age, and approximately 2/3 of these tumors have the same histology. And studies have also shown that approximately 2/3 of these metachronous lung cancers are resectable, and of these, approximately only 1/3 will have a limited resection. So, in appropriately selected patients with metachronous non-small cell lung cancer, surgical resection of the second primary can provide the long-term survival. So, this was also the conclusion of a study published by Ford et al. In 2021, where they evaluated outcomes of patients after contralateral anatomical surgical resection. So, initially, 55 patients who underwent previous lobectomy for lung cancer and presented with metachronous second primaries, they were evaluated, and these patients underwent surgery for their metachronous primary, and they concluded that the second contralateral anatomical surgical resection was possible, and although it had a higher early mortality rate, but the long-term survival was acceptable, and they suggested that for these carefully selected patients, surgical resection would be appropriate in the metachronous setting. So another study, this is the update of the Alliance trial. The Alliance trial was a study of lobar versus sublobar resection in T1A-N0 non-small cell lung cancer, which then proved that sublobar resection in these cohort of patients was oncologically equivalent to lobar resection. So these patients were followed up for a median period of 7 years, and the study of for the second primary was evaluated, and so what they found was that the rate of second primary in these patients, that is lung cancer patients who underwent surgery, the overall rate was 3.4% per patient per year, and the overall cumulative incidence was 15.9%. So overall 15.9% in this cohort had a second primary with a median follow-up of 7 years. So this is a significant number, and as we undergo more resections for lung cancer, and as patients are treated more for their first primary, the management of the second primary will be further important in the future. So finally coming to adjuvant therapy, there are no randomized trials to guide the use of adjuvant therapy in patients with multiple primary, and all of this is extrapolated from treatment with the single primary lung cancers, and it has been found that the highest stage of the tumor is the best predictor of prognosis in patients with multiple primaries, and If the patient has a resected stage 2 or 3 disease, then obviously adjuvant chemotherapy according to the standard protocols, usually cisplatin based chemotherapy is recommended. The controversy is in patients with stage 1 NSCLC with multiple primaries, because for stage 1 NSCLC, usually adjuvant chemotherapy in a single primary is not indicated. But when the patients have a disease in both the lungs, it is unclear whether the benefit of adjuvant chemotherapy will be there or not. And for these patients, the treating physician should evaluate the size of the tumor, the comorbidities, performance status, and patient preference to guide the therapy decisions. Coming to again, there are further if any of these primaries have molecular markers that are targetable, such as EGFR, ROS-ALK, then obviously these can also be used in the adjuvant setting. Also, the newer drugs such as the immunotherapy have also shown some benefit, but there are no studies for patients with multiple primaries. And I think this is a study to be done in the future. With this, I'd like to conclude my presentation, and if there are any questions, I'll be happy to answer.
Thank you, Dr. Asish. So first, let's ask some comments from Dr. Sajan and Dr. from medical. Any comments?
Sir, is there any role of PET-CT to differentiate intrapulmonary meds and synchronous multiple primary? Like this?
No, but there has been some data that shows that by virtual CT PET, you can define. But CT scan also and PET scan also depend on the uptake value.
Yes.
So the uptake value is different. It may be more likely to have the multiple lung primary rather than the metastasis from one to another. So there is a, not definitely, but they have been thinking in that line. That should be the answer.
So summary is that in case of synchronous, let's say in case of multiple primary lung cancer, one lung can have squamous cell histology and another lung can have adenocarcinoma histology. And if there is two lesions in the, let's say one have, there is no mediastinal lymph node, as we have beautifully said. There is an isolated lesion in the right lung around, that is T1 lesion, and another lesion in the left lung, that's T2 lesion. So the staging would be different. In the right lung, this one.
Again, they have said that if there is N2 disease, then we should consider it as an intrapulmonary meds. If there are obviously extrathoracic disease, then it should be considered as meds. So, if there are no, if it is N0 or at most N1 status, then only we can consider it as multiple lung primary. Again, if the histology is different, then we don't consider this at all. It's obviously different primaries.
Is there any time difference between to label it as a metasynchronous and synchronous? Like in colon cancer, we usually say that if the lesion occurs after 3 months, after 3 or 6 months, somewhere between 6 months, then we call it as a metasynchronous. Then if it occurs within less than that period, we call it as a.
It said that it was 4 years, but I said the recent classification says 2 years. And the Nelson in 2016, that could be correct for the 2016 era, but right now in 2025 we call it 2 years, because most of the recurrence it has to happen, it will happen within 2 years. Whatever happens beyond 2 years should be considered metaconus new primary rather than the distress from backup.
Sir, can we go bilevel resection or for both lung at the same time if we found such cases?
Generally, we think about this two settings. There are several approaches. For example, if we turn this right side and left side, so if we do from the lateral position one side, it will be difficult, take time to close it and change the patient to other side. But there is an approach called the subject-wide. Patients lying supine. We don't make any incision in the lung. We make the incision in the abdomen, and through it we enter inside the both sides of the lung. So particularly for the small lesions like GGO, or part solid region, which are quite small. At the same time, not entering even through the thorax, entering through the abdomen, and both lungs can visualize at the same time can be excised. So I think this is a very upcoming good approach, particularly for the GGOs and part solid regions. That's quite small.
Sir, there is a few, I have a few confusion regarding this. Regarding the lymph node sampling and lymph node dissection and comprehensive lymph node assessment. How does
So our practice is different. The NCCN guidelines, I would just the last time I am unfortunately with this mind. So what does the NCCN guidelines say? That at least 6 stations have been sampled for the systematic lymph sample. But then they say that 3 stations should be from the mediastinal, not from the 1 station. Let's suppose this is the track here. So this is from level 7, that is the mediastinal. This is the 1 station. This is also mediastinal. This is the 4R, this is also mediastinal. So at these 3 lymph node stations for any particular tumor, I'm not talking about all. For the upper lobe, it doesn't matter. For the left side, it doesn't matter. So what are the regional lymph nodes for the particular region? So at least 3 stations must be sampled. It doesn't mean there are multiple lymph nodes for a single station. This 6 out of the 6 stations, 3 stations should belong to the mediastinal lymph node, and rest of the 3 should belong to the higher lymph node. So that's it. So if you talk about simply sampling, random sampling, it means you don't take care, you just sample few stations, despite leaving most of the tissue, don't care about 3 mediastinal lymph nodes or higher lymph nodes, and that is simply random sampling, just to prove or disprove whether it's N2 disease or not. But at that time, even if you get a negative, here is the point you haven't taken out, so there is just a huge mistake there. So therefore, the NCCN guidelines say that you have to take out at least 3 stations. Another concern is total mediastinal lymphadenectomy. It means you take out what is the mediastinal lymph nodes you see, you have to take out all of them. For example, particularly for the right side, if there is a tumor in the right upper lobe, so you take out 2R lymph node, 4R lymph node, 7 lymph node, then the lymph nodes 9 along the along the esophageal level lymph. These lymph nodes are the mediastinal lymph nodes for particular for the right side. So it means all of the lymph nodes have been taken out. Whatever the lymph nodes located in the lymph, the level 1 lymph node we cannot achieve. It's already N3 disease, so there's no point to take out. So this is called radical lymphadenectomy. The next concept is, let's suppose somebody has the tumor in the right lower lobe. So it will give metastasis to this inferior mediastinal. But it's very rarely it will go to the 2R, higher upper mediastinal. So there is no point while doing this lobectomy to take out this kind of it. So what has been said that the lobe specific for this particular lobe, what stations are recommended to take out, like in the stomach cancer, T2 lymph node station depends upon the location of the tumor. When it's located in the antrum, the T2 lymph node dissection means certain groups of the lymph nodes. If it is located in the body or in the proximal stomach, the T2 lymph node station are totally different. So in the same point, this is called the lobe specific lymphadenectomy. So depending on the location of the tumor, you don't need to take off the whole. For example, the tumor is located in upper lobe. What's the chance that level 9 or level 8 lymph node will be metastasis? It is very rare, less than 5%. There is no need for taking out this lymph node. So that's for the lowest specific. But according to the NCCN guideline, they say despite the location of the tumor, you have to take out 3 mediastinal lymph node at least, and they do not recommend the lowest specific. Though they talk about the lowest specific, they say that you have to take out all the lymph nodes. That is the one concept. So that's another different topic, not related to this one. So regarding today's topic, I think it's a very fun one.
Another question, sir.
It's a budget.
Sir, त्यो लोर लोकोमा जस्तो हजुरहरूले प्यारामेट्रिकको स्याम्पलिङ यस्तो गर्नुहुन्छ सर?
हामीले के गर्छौँ भने our concept of we follow the NCCN guideline. They typically recommend this is the tumor is said about the world, right? Right side of the world, this tumor is located here. So this is the tract here. This is the carotid. So this lymph node, diaphragm, and esophagus. So lymph node 9, which is located still the mediastinal, take out. Level 8, this is located along the esophagus, so we take out. We don't take over the higher lymph. The higher lymph nodes by any way that will be taken. So we don't take any point. Level 7 lymph nodes then the subcarinal, that will be taken out. Then moving upwards, right paratrachal, that will be taken out. Level 2 are right upper paratrachal. These all groups of the lymph nodes will be taken out. That is the recommendation from level 6. So we do the same. So, okay, sir. So regarding the particular today's topic, we said that metacon's one of the definitions there are said there's 2 years of the class. So what happens when have two kinds of generally why the incidence of this kind of the lesions, multiple lung cancer is rising here because of the screening protocol. After COVID it's hugely rising because most of the patients who is screening for the COVID at the same time they detect some sort of the GGOs or parts solid. So then the concept of the solid nodules is very clear. In the solid there are a lot of classifications and a lot of the it is supporting how to differentiate benign versus malignant. And there is the subsolid nodule. There is the confusion. The subsolid nodule we have two types. One is the GGO, completely class, and one is the partial. So why I have come to this point? Mostly GGOs have got very excellent prognosis. They are very small, no solid component is there. Prognosis is excellent. But the chances of malignancy in GGO are high. If it is a part solid, means it has component of the GGOs and along with that the solid, the chances of malignancy is less, but the prognosis is poor. So the solid tumors are more invasive than the GGOs. So what I need to say is that first we have to classify them. If somebody has in the right lung, there's supposed to be multiple GGOs. How will you classify that? TNM. So we assume that this kind of tumors don't get lymphoid studies. We assume CT it was done, no distant metastasis. How do you classify the T states? It's important first, right? So for T GGOs we don't classify, just like GGO and multiple. If the patient has the GGO, it doesn't carry character of T stasis. Whereas if it's the part solid, so there is the solid region and beside that the GGO. So we take the diameter, it will be this much. That's wrong. So for the T stasis, you take only the diameter of the solid area. So according to that will be the T stasis. If somebody has got multiple lung cancer, like in the right side, this one also. So it depends upon we classify differently or the same. So giving the benefit to the patient, you want a slide Mahanamani has mentioned very beautifully. Let's suppose there is a tumor in the right upper row, and it's another tumor here in the same row. So it's said it will be better if in the lower the both of the lesions will be taken out. So in this context, this the NCCN and the UICC has declared as D3 design. So this will be considered as the intrapulmonary metastasis from the same region, rather than multiple lung cancer, except if it has got both the different histories. But we do not try to prove it or disprove it. One of the reasons will be proven, and the next one will be the productivity simply, and that's all. What I disagree, one point is said that the patient should not have the N2 disease. If it is the N2 disease, then it should be taken as the metastasis from the lung cancer rather than multiple lung cancer. We'll have to follow the classical literature from Japan. They say, let's suppose the lesion is here in the lower body. So definitely the lymphatic spread pattern will be like this, right? It will not go to the upper body instrument. So this pattern is here. At the same time, there's some this is the N2 disease for the right side. You did the PET scan, it showed the right nodal location, it has gone up to the level 7. At the same point, the patient has got the left upper location, which has gone to the level 5 and 6, not beyond. That should be considered as the synchronous lung cancer rather than metastasis. According to this definition that you have provided, the N2 disease has to be excluded. So it depends upon the which lymphatic vessel it has gone to. If the escotal lymphatic vessel no go up, like metastasis will be handled. But esco lymphatic station sorry, esco lymph node गया है, so esco अपने lymph node में गया है. It should be considered this situation. We have got a distinct difference. The restaurant the Japanese have focused a lot in this regard. Lymphatic distribution is अलग समय पसंद तब and similar भएको the difference of the we एउटा disagreement to her. अनि so the message is that it's not uncommon these days because a lot of screening CT scan is being done. And the prognosis is very good for the surgeons. I said that if there are GGOs, we have to first localize it. You cannot feel by your hand. So it's must that you the CT guided hook wire localization preoperatively during surgery or some dye injection, because during surgery you will not find out where is the region. So it's must, and the best approach is the bilateral lungs. The upcoming approach just one is making patients supine. One is then here at the same time you can visualize both lungs and you can exercise it. Most of the GCOs are located in the peripheral, that the virtue God has given that. So wedge resection is simply quite good. एउटा ट्रायलले के देखायो उहाँले भन्नुभएको कि while lobectomy is a little bit superior to the segmentectomy or wedge resection or sublobectomy. What happens to you exercise only part of the lung because it is feasible, don't need to go for the lobectomy. Then there is the higher chances because of the field cancer radiation, the remaining part of the lung will have the cancer in the future. So if the lobectomy गऱ्यो भने त लोबै रहेन भने कहाँबाट क्यान्सर हुन्छ भने त्यो कन्सेप्टले चाहिँ आएको के छ भने हायर रिसेक्सन इज अलवेज कन्सिडर्ड बेटर. बट यो टाइमले देखाउला कि यो चाहिँ जरुरी छैन. Definitely what they have been said about the NGS and every technology, that's very good. So we do the question मलाई कहाँ जहाँसम्म लाग्छ भने एउटा क्वेसन भने they say that यदि दुईटै हिस्टोलोजी सेम छ दुईटा रिजल्टको then हिस्टोलोजी त सेम देखाएको हुन्छ. Genetic mutation गरे similar देखायो. Then they have come to the NGS. So NGS केबाट गर्ने? Solid बाट गर्ने कि liquid बाट गर्ने त similar आउला. अनि solid बाट गर्नु पर्यो नि उसकोबाट पनि गर्नु फर्मालिन टेस्टिसमा गर्नु त्यो बुकहरुमा मैले मेन्सन गरेको सोझै NGS लेख्छ. NGS भनेको लिक्विड NGS हो कि टिस्यु NGS हो. मैले लिटरेचरमा सायद मेथोडोलोजीमा कतिवटा त पनि फाइन भनेको छैन कि टिस्यु गर्ने सोझै NGS भन्छ. व्हाट NGS ब्लडबाट गरेको त दुईटैको लागि उयो होला नि त भने चाहिँ त्यो फर्मालिन टिस्युबाट गर्नु पर्यो. अब त्यतिखेर त
टिमर्सलाई डिफरेन्शिएटली छुट्टै गर्न पर्छ.
टिस्युमा गर्नु जुन लेखा छ
दुईटै टिमरलाई छुट्टै गर्नुपर्छ भनेर लेखेको छ.
ब्लड त गर्यो भने
ब्लड त गर्नै मिल्दैन.
अहिलेको जमाना के गर्नु मिल्छ क्यान्सर राइट नाउ दे आर डुइङ द AI ले डिप लर्निङबाट गरेछ. उनीहरूले सबलाई प्राय जोत्नै पर्दैन. या विल शो व्हाट इज द प्रोबेबिलिटी दिस इज द सेम लिजन or is the multiple of cancer separately. म जहाँ गएको थिएँ लास्ट टाइम कन्फरेन्समा गएको थिएँ चाइनामा. इट्स भेरी गुड. दे डोन्ट डु टिस्यु बायोप्सी. इभन लिजन the probability of being benign or malignant, no need to do the PET scan. They will simply with the CT scan AI tool, they will say by 85% probability predictive value is malignant or benign. So you don't need to do the follow-up CT scan, don't need to do the follow-up PET scan. उसले बताउन सक्छ. अब किन गर्दाखेरि त्यस्तै यसमा पनि यो मल्टिपल लङ क्यान्सर यो एउटाको मेटास्टासिस हो रियली डिफरेन्ट प्राइमरी पनि त्यहाँबाट पत्ता लाग्छ. म चाइनिजहरुले कहाँसम्म पुगेको थिएँ
यस्तोमा के छ यो जस्तै राइट लोअर लोबको र लेफ्ट अप्पर लोबको दुईटै एन्डोकास्मिनर छ तर ड्राइभर म्युटेसन फरक छ. एनजिएसमा डिफरेन्ट टाइममा त्यो 7 चाहिँ यताको हो कि यताको हो कसरी?
7 त कमन पुरै 7 इज अलवेज कमन फर वेयर इज द लोकेसन.
त्यो जस्तै राइटको चाहिँ 5 पोजिटिभ आयो.
त्यही बेला मानव 5 पोजिटिभ आयो 6 पोजिटिभ आयो भने राइटको त उता त्यसरी जाँदैन कि लोअर लोबको त्यहाँ
लेफ्टको भन्नु लेफ्टको
सेभेन त कमन हुन सक्छ तर 5 र 6 मा राइट लोअर लोबको जाँदैन.
लेफ्टको नै छ लेफ्ट अप्पर 5 र 6 पोजिटिभ आयो. अनि त्यो 7 अब यतापट्टिको कसरी छुट्याउँछ?